Welcome everybody. Thanks for your time, and to those online as well. Thanks for your time here today. In a public setting without a mask, I feel a bit weird. It's almost like I'm doing something bad, but let's hope not. Okay, well, thanks, Chris, for the introduction. Today, my sort of take is to have a look at the policy process that the NHI has followed, plus some of the high-level fiscal implications, and then just briefly at the end, what are some of the alternatives that we could have a look at. So in terms of the policy process, I thought it might be apt to have a look at some history on health policy process, or health policy in South Africa. And it goes back 2.5 decades, so you can see over there, started with just at the dawn of our democracy, an ANC health paper that was written. The establishment in the late 90s of the Taylor Commission, which did some very good work. The Medical Schemes Act was passed in 98 after work from the Monopolies Commission. The Taylor Report, after a good 5 years, developed a social security proposals, which was much broader than just healthcare, but within that there was the proposal for a social health insurance. In 2004, prospects of building a low-income medical scheme option was also on the table. That didn't last very long, though. It was cancelled by 2006. By 2007, the Taylor proposals had been abandoned, and principally, you can just have a look at the year there. Obviously, the changes in the political landscape is really what prompted that change. There was also a proposal to change the Medical Schemes Act in that amendment bill, and that was also abandoned. And 2008, the NHI proposal was born. So it's been on the table for a good 12, 13 years now. The Green Paper came out in 2011, a White Paper in 2015, and then another attempt at building low-income medical scheme options, but it started and ended within the same year in 2015. A second White Paper was drafted and published in 2017, and the low-income medical scheme options started for a whole third time. By the time we got to 2019, the NHI bill had been passed by Cabinet. The Health Market Inquiry had finished its 6-year investigation into the private sector and produced its findings. Touch more about that later. And LIMS ended for a third time, so quite a lot of yo-yoing around. But in terms of this whole timeline of 25 years, there's only one substantive piece of legislation with regards to health funding that was passed, and that was the 1998 Medical Schemes Act. So a lot of proposals on the table, a lot of research done like the Taylor Commission, various aspects, but not really much cemented in terms of changing healthcare in South Africa. So it's just to give a little bit of a policy background in terms of where South Africa has been for the last 2.5 decades. But to come back to NHI, I want to touch on, in terms of the policy process, obviously any policy that gets put forward needs to have a problem statement as to what that policy is intending to fix. And if we have a look at this as the policy statement from government in terms of which was in the socio-economic impact assessment. So it states here the South African government is committed to the goal of universal health coverage. However, to date, progress towards this goal has been limited by the existing health financing system structure. Okay, so in essence, and I underline the two parts there. That's my own emphasis to say. So we focus on universal health coverage and the existing health financing system. And it's been sort of reiterated by comments like this from Dr. Mkhize, who's our current health minister, but it quite easily could have been his predecessor, Dr. Motsoaledi. So responding in a recent parliamentary QA session, Mkhize said that the primary reason for the shortage, that is of doctors, is that the public health sector has not increased in real terms in the past 10 years. And this has impacted on the number of staff that can be appointed. Okay, so very much talking to financing as an aspect of the problem statement, and as a result that we can't achieve universal health coverage. So to summarize what that problem statement is saying is South Africa does not have universal health coverage. The shortage of doctors is because the public health budget has not increased in real terms for 10 years. And this has impacted on the number of staff that can be appointed in the public sector. So that's just a summary appraisal of what they're saying. That's the problem statement. So from our point of view, then, let's go and have a look at, let's interrogate that. And that's what we've done in a whole lot of research that we've done over the last few months. So on the point of universal health coverage, I think this is a key aspect of the policy that is been incorrectly defined from the very get-go. We need NHI to get universal health coverage. Okay, but let's have a look at it. This report from the International Labour Organization found no coverage gaps in South Africa from either an inability to pay or from a lack of access. So in other words, we do have universal health coverage. The World Health Organization and the World Bank reports, I think also of 2017, found South Africa had a service coverage index of 0.67. 1 is perfect, 0 is non-existent, but 0.67 for a developing economy is very good. So we have a high level of universal coverage. And then the third and last reference on it more domestically, the Health Market Inquiry, found that South Africa provides near universal access through combination of publicly available services and the regulated private market. Okay. So the aspect of universal health coverage, and I think is a key point we need to put here, we don't have a problem in terms of universal access. We have a problem in terms of quality in the public sector, and that, I think, is more the essential, and we'll come back to that later. The other aspect then of the problem statement was that the public sector budget has not increased in real terms in the past 10 years. So again, let's go and interrogate that and have a look. So on the table that you have over here, we have the provincial public expenditure from 2010 to 2020, so a nice 10-year period there. The column in white is showing the expenditure in nominal terms. And if we have a look at that, it went from 92 billion to about 216 billion over that 10-year period. But we obviously need to account, to create a value around that, we need to account obviously for inflation and obviously for population growth over that time. So in the blue column, if we have a look at the real expenditure, and we've set the prices on the 2010 value, so in real terms then, there's been a 50% increase in health expenditure over that 10-year period. That's stripping out inflation. We still have a 50% increase in the real value. We obviously also need to take into account for the population growth, which has grown quite a bit in that 10-year period, the uninsured population being the total population minus those on medical scheme cover. Then we have a per capita expenditure in real terms that has gone up by 28% over the last 10 years, in complete and total contradiction to what is stated in the problem statement that we need NHI because there's not enough funding. There's been, in fact, very handsome growth in expenditure within the public sector over the last 10 years. And even more so because that 10-year period, we decided to go and have a look at another report which was done by National Treasury, which went back a bit further. And we found that from 2001 to 2016, again, the white column is in nominal terms, the blue in real, and the green in real per capita. So nominal grew very substantially over that 16-year period. And then when we have a look at real, we set it here in 2016 values. But again, we see a substantial increase in real terms of 135% over that 16-year period. Okay, very, very substantial increase. Again, if we obviously have to look, to be relevant, we have to look at it on a real per capita basis. But again, there we see a 94% increase in real per capita expenditure in public health sector over that 16-year period. So now, if we've got data here up until 2016 on this analysis. So if we marry that to the previous slide that we looked at and just have a look at the last 4 years in that from 16 onwards, even in real terms for the last 4 years, there's been a 12.2% increase in real per capita expenditure. So if we marry that to the previous slide showing data from 2001 to 2016, we can comfortably say that public health expenditure has doubled in real per capita terms over the last 20 years. A very, very substantial increase in public health expenditure. So it doesn't marry with what the problem statement has been constantly, that there is insufficient funding. Okay. This kind of lack of funding aspect has also been sort of transposed into another statement, and this has been used in both white papers and in the socio-economic impact assessment to state that the current health financing system punishes the poor. These are the statements made in terms of advancing the policy, the NHI policy. But if we have a look at this analysis, this was a study done by Econex in, I think it was 2017, if my research note shows, yes, it does say at the bottom there. What this shows on the left-hand bar is the source of financing for public health, and on the right where that, how that public health, how the public services are expended across 5 quintiles. And on the bottom, you'll see the 5 quintiles there. Quintile 1 is, so the quintiles are split into 5 equal share of population by households. Quintile 1, right at the bottom in the light blue, is the poorest quintile, and the dark blue at the top is the wealthiest quintile, quintile 5. And here you can see is quintile 5 contributes 68% to public health funding and consumes 12.7% in and of itself. But if we combine the 2 top quintiles, 86% comes from the 2 wealthiest quintiles, quintile 4 and 5, providing the overwhelming majority of the financing required for public expenditure, which is then you can see spread much more evenly across the right-hand side bar, which shows where the public sector's expenditure is occurring in terms of benefit to the population. And we see the wealthiest quintile, that red circle that's flashing there, is the only quintile that receives less in terms of benefit than what it contributes in. Every other quintile below that, 4, 3, 2, and 1, receive more out of in terms of benefit than what they collectively contribute into that. And the point about this, to emphasize, is this structure is very much in line with the social solidarity principle of the wealthier paying for the health costs of the poorer. So it cannot by any measure be considered to be a health financing system that punishes the poor. Quite to the contrary, if you actually see at the poor at the bottom, their contribution is very low, which is understandable. Obviously, that we accept that. But the benefit out of it is much greater, and we're all happy about that. But it cannot be described as a system that punishes the poor, which has been part of the policy process contained in both white papers and in the socioeconomic assessment, impact assessment. So to come back to the government's problem statement, we've touched on the universal health coverage and some of the financing aspects, but now the shortage of doctors. So it's impacted the number of staff appointed. How quite, I don't know, but let's have a look in terms of what the actual numbers are. So this is a study also undertaken by Treasury and amongst a few other departments. And we track here public sector medical personnel from 2006 to 2016. And you can see there a very substantial increase again, a 42% increase in the rise of number of personnel employed. Not posts, just to emphasize, this is actual employment numbers within the public sector. So it's a 42% rise. If we account again for population growth, the ratio of doctors per 10,000 population, the ratio of medical personnel to population increased by 25% over that period. So there's been a very steady, very strong rise in the number of medical personnel employed in the state. On top of that, we also had a look at what the wage increases are in the Department of Health. And I suppose this graph is not really much of a surprise. There's been, in real terms, a 55% increase in wages, average wages over the period 2006 to 2016. Obviously, this is the white elephant in the room that our Finance Minister, Tito Mboweni, is obviously emphasizing is where our fiscal problem is coming, is that wage increases have far exceeded inflation for so long. In real terms, it's consuming up an ever bigger portion of expenditure. And it's amply reflected there. That is the Department of Health specific figures. Those are all post-clinical and non-clinical. Another aspect then to look at in terms of expenditure is how do we compare internationally? Because obviously the analysis we've looked at here is only internal within South Africa in itself. So what we decided to do a little sort of experiment here is we took South Africa's per capita GDP and we then doubled it to whatever that was, and we chose the country that was closest to double South Africa's per capita GDP, and then chose all the countries between South Africa and the country with double. So that gave us a cohort of about 25 countries, including South Africa, from which we then decided to do some analysis in terms of their health expenditure and their outcomes. So you can see that list there. I think virtually everyone a developing economy, just much like ourselves. But the emphasis here is that all of these countries are wealthier than South Africa on a per capita GDP measure. Okay, so we're the poorest in this graph. So if we have a look here, on the bottom horizontal scale is the per capita GDP, and on the left scale, on the vertical, is the health spend, also per capita GDP in the public sector. So South Africa is on the far left on per capita GDP. As I said, we're the poorest country in this cohort of this analysis. And then we have a look at how our health expenditure on a per capita basis also compares with these 25 countries. And we see there that in the red block, there are 14 countries out of the 24 that spend either the same or less than South Africa, although they're much wealthier than South Africa. And there are only 3 countries that spend significantly more than South Africa, than you saw there in the 3 red graphs. So out of the 25 countries, 22 are pretty much all in, not all in line, but certainly not well in excess of what South Africa's expenditure is. There are a few that are slightly more, but the vast majority are either the same or less in terms of per capita spend. Now, if we take that same data and we then analyze against, again, the health expenditure per capita up on the left-hand side and compare it with the 5-year mortality rate in the country, we see a totally different picture come out again. So South Africa is now on the far right hand with the 3rd worst outcome in terms of 5-year mortality rates, within that expenditure that sits quite in the middle of that grouping. And you can see in the red block there, there are 14 countries inside that red block that spend either the same or less than South Africa on per capita GDP. And most of those, I think it's 10, achieve significantly better 5-year mortality rate than South Africa does. So our expenditure is right up there with the richer peer countries, but certainly our outcomes are lagging far behind if we take just this one measure. If we go and have a look at infant mortality and maternal mortality, we'll see exactly the same picture arising out of that. Again, our expenditure level doesn't quite marry with what the outcomes that we should be getting with that expenditure level. And just I think as a matter of reference here, you might have noticed this one country that sort of pops up with expenditure well in excess of anyone else in this group, and that country is Cuba, which obviously, as we all know, has got a fully nationalized health system. Its expenditure sits at about 13% of GDP, which for a developing economy is virtually, in fact, it's the only outlier in the world in that space. But again, to emphasize, that's a nationalized health system, very much what the NHI proposals are proposing. I would say with South Africa's enamored relationship with Cuba, that the NHI proposal has pretty much been modeled on what the Cuban health system is. But, and there you'll have it, expenditures way through the roof. So just to conclude in terms of the policy process and what that came about, we come back to this policy statement that it was presented in the SIA and in the white papers. Well, now this is the data we've looked at, but health expenditure in real per capita terms has doubled in 20 years in the public sector. Our expenditure compares very favorably with our richer peers. So certainly there's not, even by international comparative persons, are concerned with expenditure. The financing system also embraces the principles of social solidarity, so that there's a great subsidy from the wealthier to the poor in terms of allowing them to access healthcare. And then the last point is the universal health coverage argument is we already have universal health coverage. There's no policy, there's no need, there is no problem with regards to health coverage. It'll be the quality of the healthcare which is the issue, and that we'll touch on possibly later. So that was the review of the policy process. The idea now is to have a look at what the fiscal implications are of the NHI proposals. I think at very high level here to break it down here between private sector and public sector. So the private sector is mainly funded through voluntary contributions by members to medical schemes, and there's obviously also out-of-pocket expenditure by both insured and uninsured citizens on the private sector providers. And the figures we get to there are about 4.6% of GDP and a total expenditure of 234 billion. We used the 2019 figures to make sure we had all the data together. But I think the emphasis on this as well, the private sector is voluntary. So it's voluntary choice by citizens to partake, private commercial arrangement. And the vast majority of that expenditure is with after-tax money. There's a small credit in terms of which equates now to roughly about 10 or 11%. So there's some small relief, but the vast majority of the expenditure is with post-tax money. Public sector is obviously funded through taxes generated by taxpayers and corporates, etc. The allocation then devolves through the Department of Health to the provinces and to the various health districts through the conditional grant and the provincial expenditure allocation, or share as it is. That gives an expenditure in public sector of 4.4% of GDP, or 223 billion. So the two sectors are very close in terms of size, although they do serve completely different population sizes. There are the 52 district health authorities in which the districts, if you like, in terms of which the public, the healthcare is then provided. We did exclude from this road accident fund and the compensation fund as a consideration. Arguably it might be included in there, but it's publicly funded, but almost all the delivery is actually in the private sector there. But in principle, the point here to look at is if we take this public sector expenditure and then allocate it across the uninsured population, you get an expenditure of 4,500, just over 4,500 per person per annum. And I'll just bear that number in mind because we'll come back to it just now in terms of comparing it to how it's going to come out in the NHI world. So the basis of the NHI proposal, just very broadly at high level, is that the expenditure that occurs in these two sectors can be put together into one pot, that being the NHI fund. And then we would have control of 8.5% of GDP. That was the desired number, by the way, in the white paper. Although the current expenditure between the two exceeds that, you'll see it's 9%. But we kept it at 8.5% because that's what the white paper, the green paper and the white papers both said. The proposal then is to remove the medical tax credits, which gives about another 26 billion, and to also remove the subsidy that the state provides to the employees currently for medical scheme participation, which amounts to about 35 billion. That then gives a pot there of 284 billion, or 5.6% of GDP. So the balance to get to 8.5% is another 2.9% of GDP, or 148 billion. And the proposal there is to raise dedicated NHI taxes from taxpayers to obviously make up that difference. Now, you know, fiscally, I've spoken to a number of economists who've all just balked at this number, saying it's just simply, even prior to COVID and the impact, it was out of the question that amount was going to be possible to raise. So I take it as there's not, although we live in strange times and I think stranger things may have happened, but let's see how it goes. But that then gives a pot of 432 billion. This is again still all in 2019 terms, by the way. And again, to come back, bring that down to a per capita number, the proposals of the NHI is to sideline medical schemes. Medical schemes won't be able to compete with the NHI. So whatever the NHI fund covers in terms of medical cost expenditures, the medical schemes will not be able to do that. So therefore, those members that are in the private sector will be forced into the NHI fund. So if we divide that 432 billion now across the entire population, because that is what the proposal is, to bring the entire population into the NHI fund, we then get a per capita expenditure of 7,385, which is 64% higher than the current public sector per capita expenditure. So a significant improvement in that budget. I thought this little cartoon might be apt in terms of how some taxpayers might feel about it. But anyway, I think it was courtesy of Dr. Jack who quite aptly put it there. But anyway, let's come back to this point now. Yeah. The issue of whether or not those taxes can be raised is some very serious question. I think specifically now after where we are now in terms economically with the massive growth in debt, the economy stalling, massive unemployment, the prospects of raising that to me seem very, very slim. Might be an arguable or debatable fact, but let's leave that and accept that for the time being. We then left with 284 billion, which is basically the public sector budget plus those medical tax credits and the state subsidy, which gives, if we're presuming the proposal is still to make it a complementary system so that medical schemes can't compete, we then have a per capita budget of 4,855, which is only about 7.7% higher than the current public sector per capita budget, or expenditure, if you like. Now, I'm going to put a big red circle around that state subsidy aspect, because as we see it playing out now, you've seen the standoff that's sitting between the labour unions and government in terms of wage increases. Now, if the state's going to come along and say we're also going to take away that 35 billion rand subsidy, well, there might be question marks whether they're actually going to be able to achieve that funding. So if we scratch that out and say, okay, let's leave that, then what do we have left? So then that drops the NHI fund allocation to 249 billion, which on a per capita basis then says we've got 4,256 rand, which is actually 5.5% less than what the current public sector per capita health expenditure is. So you see how onerous this is all looking in terms of a lot of ifs and buts that are going to get to the hypothetical lot more money pot that the NHI proposals are all pretty much predicated on. So if we come back to this aspect of expenditure between the two sectors, currently in the private sector there are 9 million lives, 9 million citizens covered under medical schemes. If hypothetically that was a 50% better ratio and there were 13.5 million people on medical aid, the public health sector, the same public sector budget, so it hasn't changed in value, would then improve by 10% because it's obviously being divided by less people who are reliant on the public sector budget. So at no cost to government, it can improve its allocation quite handsomely if it facilitates a functional and efficient private sector, which is what we'll touch on just now on the health market inquiry, which should be done. So instead of having this controversial sort of antagonistic approach around the private sector, if it enhances the private sector, that it widens up to more citizens, it actually alleviates public budget and improves it without any more money being have to put into the public sector budget. So we've touched on the funding aspects now and how all of that is supposed to be rolled out, but the other aspects is obviously you can't have a health system unless you have providers who are delivering care. So yeah, again, I've split between private and public. And as I said earlier, it's in the private sector, it's either out-of-pocket or medical schemes that cover the vast majority of the expenses there. And in the public sector, obviously, it's the annual department's budget, the conditional grant, and the provincial equitable share. There is the aspect of the UPFS means test. I think on the surface of it, from what I see, there's not much being collected in terms of that. So I don't think there's much more money coming into the public sector on the basis of that. But if we then look at the proposal for providers, so yeah, we have the NHI fund, and then medical schemes will change their role from their current role to only being complementary. Sorry, I just need to take some water there for this throat. So the complementary aspect means that the medical schemes will only be able to cover non-NHI services. So whatever's not in the NHI package, they could cover. So that brings the private sectors or compels them in to contract with the NHI fund, specifically if those providers deliver services that the NHI is going to monopolize in terms of its structure. So if, say, for example, it's all dental work was going to be covered by the NHI fund, then dentists would have to contract with the NHI. There won't be a private sector for that, just to use that as an example. So, but we don't know what's in that package yet, so it's obviously very difficult to say how it's going to be impacted. But one of the committees within the NHI fund will be a pricing committee, which will then determine the remuneration levels to providers, both public and private. And we also have very little idea as to how that is going to pan out. But that will leave private sector providers then to contract with medical schemes, but only for the complementary package. Again, I say what that is, we don't know, because the basket of care that the NHI is proposing is unknown. It hasn't yet been outlined as to what we propose on that. So there's a big question mark here: is what will this remuneration level be to both public and private sector in terms of delivery of care? Because if it's not realistic, if there's a force down in price to beyond what the private sector providers can sustain at, then we're facing another major problem, which is this one over here, the brain drain. And we can obviously ill afford to lose any more doctors, because at a national level, South Africa is short of doctors. As an example, when Cuba nationalized their health system, within a year they lost a third of all medical personnel that left the country. And health outcomes in Cuba suffered dramatically for about the next 10 years. It took them that long to catch up again in terms of outcomes because the loss of doctors had such an impact on outcomes. So I think I want to touch here a little bit on some more philosophical points, the rationale of monopolies. So the NHI fund is a total monopoly. It will control the healthcare for all citizens, for whatever that basket of care eventually does pan out to be, but it will be on a monopolized basis. Medical schemes won't be able to compete and citizens will not have a choice to opt out of the system. So here's Professor Michael Porter, Professor of Economics at Harvard. History tells us that monopolies that are truly benevolent and effective are rare. And he's a specialist in the healthcare industry and has been creating something called value-based competition on results. And the essence of it is you need competitive forces in healthcare to make them work. Monopolies don't work. Closer to home, one of our latest speakers, Professor van den Heever, the NHI bill proposes to centralize what should be decentralized. So this whole aspect of controlling every aspect of healthcare delivery, there are numerous international examples which show that a decentralized approach is much more effective in terms of improving outcomes and managing costs for that matter. The purchasing function should not be placed within a national structure as this distance from delivery will institutionalize massive inefficiencies. I do think he might have been kind in terms of saying massive inefficiencies. We probably have more the spectre of massive and rampant corruption, which is essentially what is most likely to happen in a structure like this. Lastly, on this point, one of my favorite authors, Nassim Taleb, who's considered to be, by many, to be one of the world's foremost thinkers on risk management. And he says, we've lived since the dawn of modern times under the illusion that centralization is better, more efficient, and that large works better than the small. But the truth is that large public projects, under the myth of cost savings, incur disproportionately large cost overruns. Now, I can give you two homegrown examples, Medupi and Kusile. And I mean, they are years behind, and they are orders of magnitude over in terms of budget, because once you're in to such a big project, you can't extract, you're in. So it's the same with NHI. Once we build this, if it doesn't work, there's no alternative. So it's a huge risk. And I think this is the essence of what we're saying, is that if you tie everything to one horse, then, if it doesn't work, if your horse doesn't win, you've lost it all. Competition in a competitive open environment is much, much better. The last point I'm going to touch just in terms of finances is this aspect here. Now this is, I think from the Department of Health's point of view, the big white elephant in the room. This number has been growing at a ridiculous rate for the last 5-6 years. And it's now sitting at the last Auditor General report clarified this at 105 billion rand. Now, if we compare that, this last 2022 budget speech, the public health budget was 248 billion. So that liability for medical malpractice is sitting at 42% of the total health budget. Now, obviously, that doesn't all get paid out at once. It does get paid out over time as awards, get awarded by the courts, however that comes. But the rate at which it's growing, we estimate that if it carries on at the same rate, by 2026, it'll be equal to more than 80% of the Department of Health's total budget. So this is almost like an Eskom debt problem to South Africa. This liability problem could be the same, because the only persons that are going to carry this are the taxpayers, just like we would be the taxpayers carrying the burden sitting inside an Eskom. And there's been very little in terms of addressing this issue other than to avoid the liability, changing the rate of compensation, how it's done, et cetera, et cetera. But in terms of addressing the quality issues in the public sector, which obviously where these liabilities result from, there's really been virtually nothing to have been said about that. But the numbers are growing and very dramatically year on year. So just to wrap up in terms of this, I wanted to have a look at the health expenditure as a percentage of GDP between public and private across those other countries that we looked at earlier, the 25 countries. I did strip out Cuba because unfortunately it's such a massive outlier that it skewed all the numbers, so it is minus Cuba. But I want you to have a look at here. This is public health expenditure as a percentage of GDP on the blue bar, and the average is slightly under 4%. Now these are economies wealthier than ours, They also are developing economies, but as I showed in the example how we chose them, all of these countries have a per capita GDP that's higher than ours. South Africa wants to create a NHI which achieves a public health spend of 8.5% of GDP. It doesn't exist anywhere in the world. There is no such developing economy that has got that kind of expenditure in its health system. The green line is private health expenditure, including out-of-pocket, which we added there, and the average there sits at just over 3%. So I think this just to emphasize that the proposal to get public health expenditure to the level of 8.5% GDP is unprecedented anywhere in the world. I mean, we searched through every country we could find. Can't find a developing economy at that level. So the last point I want to just discuss now before I wrap up is the alternative paths, and just at a very high level. And I think the emphasis to put here is that there is no real clear-cut path that we can say this is where we absolutely think this should go, because this is such a difficult and complex issue. The health systems are inherently massively complex, and when you're trying to marry how the private and public sectors work together, it adds an even deeper layer of complexity. So the point is, these are discussion points that I think that should have been brought into the policy process that have been sorely lacking, unfortunately, in a way. There's been a very absolutist stance from government from the very get-go. From 2009, NHI was the decided policy proposal. It wasn't that they went through a policy process and then said, what is the best solution? It was, this is the best solution, and let's just alter the policy process to make sure it fits with that. Which is why, by the way, a lot of the statements in the policy process don't stand up to scrutiny for exactly that reason, because the policy had already been decided 12 years ago. So the private sector, we've had the health market inquiry spent 6 years gathering evidence, providing a blueprint to make the private sector more affordable, more efficient in terms of how it delivers, and in essence expand its cover base to a much larger portion of the population. As I showed earlier, the more the private sector expands, the better the public sector gets in terms of its budget because of the per capita allocation. Mandatory coverage, it was, for my part, slightly disappointing that the health market inquiry didn't recommend it, although they did state that it is in principle something that needs to be adhered to eventually at some stage. It needs to come in, and their recommendations were to phase it in, which I do think is probably quite a reasonable and probably more mature response than trying to impose it all at once. But it's very important because the private sector suffered from massive cost increases because we have the social solidarity principles of open enrollment and community rating, but there's no protection for the medical schemes because members can anti-select the system by moving in and out of the system as and when they choose. Some ideas that we've sort of looked at is possible VAT exemptions on private health expenditure. You know, it used to be private medical services were not VAT exempt up until about the mid to late 90s, when VAT was then put directly on top of health expenses. So prior to that, there was no VAT on health because it was deemed a social good. But I think we could get to some extent of certainly bringing certain expenses to be VAT exempt, just as much as there is on certain food parcels. And we could look at the development of the low-cost benefit options, which has kind of revived again, but not really sure where it's going. But nonetheless, possibly that basket of services could be VAT exempt, which would then improve affordability to some extent around that. And also, we think in a medical subsidy rather than a medical tax credit. So the tax credit now, I think it's more progressive than what we used to have, but it still unfortunately only benefits those who are taxpayers. So if you're below the tax threshold, there's no advantage to the tax credit. And possibly you can convert that into a medical subsidy, which is given to the medical schemes to allocate to these low-cost benefit options, which would then make affordability a much improve the affordability of those products. If you add to that a lot of companies willing to subsidize products at this level, you really could get to a point of being a very affordable alternative low-cost package for many millions of South Africans. In the public sector, I mean, there's the spectre that has sort of emerged from the last year and a half, a bit of the Zondo Commission. Obviously, it's rather depressing at times to sort of see the extent and breadth of what has happened and the corruption that's gone with it. But the public sector is no different. It has been fundamentally dismantled in terms of its capacity to deliver care because of this practice and the resultant malfeasance that comes with it, in terms of the corruption, in terms of unqualified people not sort of understanding what to do. I had a story the other day from somebody who had visited a hospital, public hospital, to say trying to find the hospital manager, and somebody that he had to find to open the door, they found cobwebs in the hospital manager's office. He hasn't been there in however long it takes to develop cobwebs, I don't know, but certainly not a short space of time. So accountability is a key issue here. We've seen how the public sector budget is not out of line internationally. It has grown substantially in real and per capita terms for the last 20 years. We should be delivering much better healthcare. There should be better outcomes there than what is achieved. It can only be a lack of accountability that is avoiding that issue. And that, I think, will come from leadership, getting the right leadership into the key positions in the department, coming right from the top and getting that fixed so that we have better outcomes, that people actually can rely on the public sector comfortably. Raise this as a question mark. We had a health market inquiry for the private sector. Do we need one for the public sector? Do we actually all know what's going on in the public sector to the extent of the problems that are besetting it? The outcomes we can see are obvious. There are problems there. We need to, how do we address them? Maybe we don't know. Maybe there are answers to that. And maybe it can get to the point where the public sector, if it can build up its capacity, build up its skill, and be delivering good outcomes, it could actually be competition for the private sector, which if we have two efficient and functioning sectors competing with each other, we all know what happens when that happens. Costs go down, quality improves. But at the moment, the private sector can operate completely on its own. It's got no challenges from anyone. Anyway, that's it from me today. Thank you very much. I believe Patrick Brasher will be speaking up next. Thank you very much for your time.